Thanks, Dan, and really appreciate the invitation to be here. This is a long, kind of convoluted title, but let's dive into this here. These are my disclosures. When we talk about aortoiliac occlusive disease, we know what the indications for. It's disabling claudication or critical limb-threatening ischemia. Traditionally, the gold standard for especially complex disease, TAS C and D lesions, has been aortobifemoral bypass with excellent patency rates. But I think that this is one case where the open surgery is no longer the gold standard. And I think in today's era, endovascular therapy has been proven to be safe and durable and should now be considered first-line treatment for a lot of these patients. And that's in line with some of the most recent guidelines here. Here are the most recent AHA, ACC guidelines saying that endovascular procedures are effective as revascularization options, even in patients with TAS C and D lesions and with a high level of evidence, class 1, level A recommendation. So I think when we're talking about ostial iliac disease and distal aortic involvement, what we're really trying to decide is this primarily iliac disease, in which case we're usually using a kissing iliac stent approach, and you can use bare metal stents, self-expanding, balloon expandable. You can use covered stents as well, and I'll go into a little bit of that. Or are you dealing with really aortic disease, distal aortic disease, that may or may not also involve the iliacs? And that's when you start talking about aortoiliac stenting using techniques like CRAB or actually even using EVAR stent grafts. Most people are familiar with kissing stent techniques. We've been discussing that here on the panel, where we generally use balloon expandable, covered or bare metal stents. They're deployed simultaneously into the bilateral common iliac arteries, extending up a little bit proximally into the distal aorta, deploying them simultaneously to kind of equalize that cross-sectional area at the ostia of both iliac arteries. And there's a fair amount of data showing that results of kissing iliac stents are quite good. It is controversial as to whether or not this is better done with bare metal stents or covered stents. I do think, however, that covered stents have some potential advantages, particularly for complex lesions, those TAS C and D lesions that we're talking about, CTOs like the one that George is dealing with right now. I think that it's favorable for kissing stent configurations, and I especially like covered stents for highly calcified eccentric lesions where there's risk of rupture. And the theoretical advantages of these are that we can prevent in-stent restenosis, potentially have improved patency over bare metal stents, and decrease some of those risks of complications, particularly embolization and perforation or extravasation. There is some data available. The best probably is from COBEST, even though it is a flawed trial as it is, but this was a prospective multi-centered trial with up to 5 years of follow-up comparing the Advanta or ICAST covered stents with bare metal stents in aortoiliac occlusive disease. And the covered stents in this trial had lower restenosis rates, but especially in the complex lesions, TAS C and D, and this is the primary patency curves comparing bare metal and covered stents, showing an advantage in these complex lesions with covered stents. That does also seem to be the case in this more recent meta-analysis, looking at a number of studies showing better patency for covered stents, and specifically in that complex disease subgroup cohort, that benefit was even further exaggerated. I'm going to talk a little bit about some of these advanced techniques, CRAB, or covered endovascular reconstruction of the aortic bifurcation. This is kind of a modified kissing stent technique utilizing covered stents to reconstruct the aortic bifurcation in distal aorta. There are some studies showing that theoretically with some improved geometry, that may eliminate some of the unperfused dead space that you get with kissing stent approach and theoretically improve patency. There's some limited data that's been out there, but suffice it to say that at least initial primary patency at 1 and 2 years for very complex lesions appears to be pretty good and comparable to aortofemoral bypass. I'll show you a CRAB case example. This is a patient who had rest pain and had attempt at percutaneous endovascular revascularization at another hospital that ended up being aborted when things went kind of sideways. She has a number of comorbidities. You can see on this study that she's really got a distal aortic occlusion, heavy vessel calcification, complete occlusion of her common and external iliac arteries as well bilaterally. In this case, from the right side, we were able to get up from a retrograde femoral approach into the true lumen. That was not the case from the left, but we did get a wire that went from the left to the right, so we did a little angioplasty there, and then that subsequently created a communication with the true lumen that we could then get a wire up from the left side. If that hadn't worked, like George, we would have come from an upper extremity approach to remedy that. This is a predilation with undersized balloons initially at the aortic bifurcation and extending into the aorta. When we use the CRAB technique, first we place the larger covered stent in the distal aorta. It's initially deployed undersized, so this is an 8L VBX 8x79 device. It was placed in the aorta. The proximal half of that device was further post-dilated to match the proximal aortic diameter with a larger balloon. Following that, we rewire from mixture from both sides, and then we placed kissing VBX 8x79 covered stents into that aortic stent on the bottom end. And then, as we just discussed, I used self-expanding Viabond to reline the distal external iliac arteries in this case. This is the completion angiogram with a completely reconstructed distal aorta and bilateral iliac arteries. Now, you also noticed in the groins, and I didn't dwell on this initially, there is certainly a role for hybrid procedures, particularly when the common femoral arteries are involved as well. And in this patient, the common femorals were actually occluded. So we had exposed those. We punctured the common femoral directly, placed all of our stents, actually brought the Viabonds out the bottom end, then did an endarterectomy, trimmed and tacked the Viabond and patched over that. And that gives you a really nice kind of interface there between the Viabond and the endarterectomized vessel. There is also a role for treatment of some of these really complex cases with EVAR stent grafts. Data on that is really quite limited. AFX and excluder bifurcated stent grafts have both been used for occlusive disease, and I've used both in my practice. Typically, these are going to be for the task D aortoiliac occlusions, and oftentimes, well, if a patient has also combined aneurysmal and occlusive disease, that's another indication to use an aortic stent graft as opposed to just bare or covered stents. High rates of technical success and primary patency for these approaches have been described, but keep in mind it is expensive, and clearly it's an off-label therapy. This is some images from a patient that I treated with a long infrarenal aortoiliac occlusion. This was done percutaneously, in this case with an AFX device, reinforced with VBX or ICAS stents in the limbs and the iliacs, and you can get a very nice result, and this is durable for a number of years that I'd followed this patient afterwards. So in conclusion, I think the data and guidelines support endovascular revascularization as first-line treatment for all aortoiliac occlusive disease, even including TAS C and D lesions. Patency rate for those lesions are actually excellent and rival that with surgical therapy, and covered stents may seem to have better patency than non-covered stents, particularly in the most complex and advanced disease. Endovascular treatment with covered stents achieves patency outcomes that are comparable to bypass, but without the associated morbidity and mortality of what can be a major vascular procedure. Thank you.